Good morning. We're privileged to have our colleagues from Texas and specifically the Baylor College of Medicine with us this morning. And I am going to introduce Dr. Flynn, who's going to introduce the rest of our speakers. Dr. Flynn is well known to us as the System Vice President of the Texas Division for the Physician Enterprise, whose responsibilities include growing our diverse provider services and networks, as well as building aligned strategies that are inclusive of our medical groups, CINs, ACOs, academic partners, and community clinicians. Most recently, he was the Dean of Clinical Affairs and Executive Director of the University of Chicago Health Plan at the University of Chicago, Medicine, as well as president of the University of Chicago Medicine Care Network. Prior to that role, he was a professor of medicine, as well as associate dean and executive director of the Clinical Practice Association at Johns Hopkins Medicine and chief medical officer of their ACO. John is a good friend and colleague, and important leader of the physician enterprise here at CommonSpirit Health. Now, John has a little bit of a frog in his throat, but we think he can do it, and if not, we'll rescue him. So, John, good morning.
No, thank you very much, Gary. So, yeah, my first disclosure is I'm not a cardiologist. I prepared my fellow Baylor College of Medicine faculty members to serve to my forehand in any of their discussion. If they can work in a rheumatology-based cardiomyopathy, I would most appreciative. Let me first introduce my colleague, Dr. Jessica Brown, who is at our Woodlands North Houston Heart Cardiology practice. Dr. Brown is a fellow at the Texas Heart Institute and did her fellowship in advanced heart failure and transplant care at the Houston Methodist Hospital. Dr. Brown has been with us on faculty since 2016 and has a large and robust clinical practice in cardiomyopathy. Dr. Ajith Nair is associate professor at the Baylor College of Medicine, specializing in cardiomyopathy and advanced heart failure, as well as mechanical circulatory support. He serves as the director of the Baylor St. Luke's Advanced Heart Failure Clinic with a research interest in cardiomyopathy, pulmonary hypertension, and advanced heart failure therapies. And Dr. Nikolaos Diakos, who will be beginning the presentation, is an interventional cardiologist at the Texas Heart Institute and has been involved in a number of pioneering treatments and devices dedicated to treating heart failure. He has significant clinical and translational research accomplishments in this field. So, Dr. Diakos, please lead us off in this presentation.
Thank you very much, Dr. Flynn, for the very kind introduction. I'm about to start sharing my screen here.
It looks good. Thank you.
It looks good, huh? Yes, thank you very much. It's an honor to be here. I'm working both as a heart failure and interventional cardiologist at Baylor St. Luke's Hospital. And the next 30 minutes, me and my colleague, Dr. Nair, we're going to attempt to guide you through the pathophysiology of heart failure, both the one with reduced ejection fraction and the one with preserved ejection fraction. And just to give you an outline how important the problem is, we can safely say that heart failure is a global pandemic. 64 million people are affected worldwide. And if you look at people over 40 years old, 1 out of 4 will develop heart failure in their lifetime. Only in the United States, we have 6.5 million people having heart failure. And we can say now that it's the leading cause of hospitalization in patients more than 65 years old. And the cost is high. It's 33% of the total Medicare cost. So you can realize we're dealing with a very serious problem. And we're happy to give those talks so that everybody is aware about the battle we have to give the next years to reduce those numbers. What is the survival? if we take people that they have heart failure and they're diagnosed with heart failure, in 5 years, approximately 50% will be alive. And the survival in 10 years is really dropping to 10%. And this slide shows us the most common causes of heart failure. The leading cause is ischemic cardiomyopathy. As you see, it's 40%. Then there's a big portion of the pie that we call dilated cardiomyopathy or non-ischemic dilated cardiomyopathy. And you can see it's 37%. And you can see in this part of the pie, we include the chemotherapy-induced infectious diseases like HIV, the toxins like alcohol, the myocarditis, and a big part of this 37% is the one that we call idiopathic, the one that we don't know the cause. Going back to the pie on the left, valvular cardiomyopathy is about 10%, and the same is hypertensive cardiomyopathy. Now, before going through the pathophysiology, I would like to give you some definitions so that we will be able to understand the terms that we will be talking. And then I will follow with a few slides about the classification of the heart failure. So the first word I would like to define is the cardiomyopathy. Cardiomyopathy is a genetic or acquired disease of the myocardium. Now, heart failure is a syndrome. It's a clinical syndrome that it's complex. It includes symptoms and signs, and the signs and the symptoms stem from structural and functional impairment of the heart that leads to impaired ventricular filling or impaired ejection of the blood. And talking about ejection, there is one term you will be hearing all the time is the ejection fraction. In layman's terms is what's the percentage of blood that is pushed out of our heart during one cardiac cycle. And it's defined as the end diastolic volume minus the end systolic volume divided by the end diastolic volume. And it's always a percentage. Now, how do we classify heart failure? There are different ways that we classify heart failure for the purposes of our clinical practice. So the first is based on the ejection fraction. And we have people with heart failure, what we call reduced ejection fraction, when the ejection fraction is less than 40%. We have people with preserved ejection fraction when the ejection fraction is more than 50%. And we have patients with what we call mildly reduced ejection fraction, where the ejection fraction ranges between the 40 and the 50% range. Now, the American Heart Association and the AACC classify the heart failure in 4 stages. The stage A is the people that they are at high risk of developing heart failure. It's the patient that they have hypertension, coronary disease, diabetes, or a family history of cardiomyopathy. This is stage A. Why does this stage exist? This stage exists so that it raises awareness that these people are at risk, and we have to keep a close eye on us, on them, on our clinical practice, and make sure that they will not develop heart failure down the road. Then we have stage B, which are the patients that they have LV dysfunction, which is asymptomatic. For example, someone had a previous myocardial infarction. His ejection fraction dropped from 55% to 40%. He's stage B. He doesn't have symptoms. He doesn't feel short of breath. But it's someone that potentially can progress to advanced stages. Then we have the stage C, which is the symptomatic heart failure patients that they have structural heart disease and they have symptoms such as shortness of breath, fatigue. They exercise and they feel really tired easily. And then finally, we have the stage D. This is the end-stage heart failure. This is the refractory end-stage heart failure when the patients develop symptoms at rest despite we have them on the maximal medical treatment. Then the last classification we use is the functional classification from New York Heart Association. All of you may have heard that. And it goes, again, stages 1 to 4. 1 is someone that has no limitations in the physical activity. Class 2 are patients that they have slight limitation in the physical activity. What does it mean? They mean that when they do their ordinary physical activities, they can develop symptoms of fatigue. They feel comfortable when they rest, but then they can develop symptoms of fatigue when they do what they can do commonly in their activities. And then the stage 3 is when you do less than your ordinary activity. You do less what you used to do, and then you start developing symptoms. And then, of course, 4, you cannot carry any activity without having symptoms. I put on the side that you keep in mind the neurohex association class can improve the same way, can go worse. So a patient that is now your association class 2 may present to your clinic a few weeks later, and for example, after a flu infection, and they may be neurohex association 3 or maybe neurohex association 4. Now, moving to the pathophysiology of the heart failure with reduced ejection fraction, everything starts with an initial insult, a myocardial insult. You can call it a heart attack. You can call it a viral infection that causes myocarditis. You can call it a genetic mutation that is causing dysfunction in the myocytes. So this initial insult can lead to cardiac dysfunction. The next step is we try to compensate for this cardiac dysfunction, and there is what we call neurohormonal activation. What does this include? It includes the renin-angiotensin-aldosterone system activation. It includes a raise in the catecholamine and the catecholamine activity. It includes activation of the endothelin. And all these can lead to renal vasoconstriction and fluid retention. And as a result, we start developing the heart failure symptoms. Now, at the same on the right, you can see that cardiac dysfunction initially will have some compensation with the neurohormonal activation, but then down the road we develop hemodynamic decompensation, leading to increased preload, increased afterload, which is the load that the heart sees when it squeezes, and as a result, decreased cardiac output. Now, if you take together the neurohormonal activation that is initially compensatory, but then it leads to decompensation, and the hemodynamic decompensation, those two can act together and cause what we call LV remodeling. LV remodeling is the change in the structure of the heart in response to those stimuli. So the heart initially gets thicker to compensate, and then down the road, it gets dilated, and then we start having leaky valves, and it gets weaker. So those two mechanisms lead to LV remodeling, and the LV remodeling can lead to further cardiac dysfunction. So you can see, initially we compensate, and then we enter a vicious cycle that leads to decompensation and progression of the heart failure. And this is where the role of medications come that I'm going to be talking later. Now, moving to what this hemodynamic decompensation can cause, I'm seeing you on the left the famous Frank Starling curves that every one of us have been studying, and those who are studying from their boards, and they may be seeing. And so these are the curves that show the relationship between the stroke volume and the LV end diastolic pressure. Look the curve on the red color. The same stroke volume, the same end diastolic pressure leads to higher stroke volume, while the curve on the green that represents the heart failure means that the same load of the heart leads to lower stroke volume and lower perfusion of our peripheral organs. And just to make it a little more complicated, we have also the pressure volume loops that indicating hemodynamic decompensation. The green loop is a normal heart, the red loop is a failing heart. And what happens when the heart fails, the loop moves to the right and up and then decreases in the diameter. What does this mean? By moving to the right and up, that means that for the same end diastolic volume inside the heart, we develop higher pressures. Higher pressures, more pressure to the lung, more fluid extravasation from the capillaries, pulmonary edema, shortness of breath. Now, also, we can see that this line drops in slope, which means that the contractility of the heart drops compared to a normal heart. And then you can also see the distance from here to here is the ejection fraction, and from here to here is the normal ejection fraction. And you can see that there's a reduction in the ejection fraction in the failing heart. So increased filling pressure, decreased contractility. Now, we have to make sure, as we said, that our patients are on good medications. And I'm going to show you how these medications are acting on the pathophysiologic graph that I showed you before. I'm not going to spend a lot of time about dosing and guidelines about these medications, because we're going to have a separate, in a week from now or 2 weeks from now, a separate grand rounds explaining those. But I will just say there are 4 major groups. We have the beta blockers, we have the ACE inhibitors, angiotensin receptor blockers, and angiotensin receptor neprilysin inhibitors. We have the mineralocorticoid receptor antagonism, and we have the sodium glucose transporter 2 inhibitors. And let's go back to our graph. You see, we were talking about neurohormonal activation. Neurohormonal activation is a compensatory mechanism at the beginning, but then if it keeps going, it's going to lead to LV remodeling. So we have to block the neurohormonal activation. One way to do it is by blocking the renin-angiotensin-aldosterone system. And this is the system I'm talking you about. So angiotensinogen, with the help of renin, becomes angiotensin 1. With the ACE, becomes angiotensin 2. Then angiotensin 2 activates the production of aldosterone. Aldosterone works in the aldosterone receptor and leads to fluid retention, sodium retention, cellular proliferation. And the same as angiotensin 2, sodium and fluid retention, vasoconstriction, cellular proliferation, increase sympathetic tone. And we can block this mechanism by blocking the ACE using ACE inhibitors. We can block the receptor of angiotensin using angiotensin receptor blockers, or we can block the action of aldosterone in the aldosterone receptor by using the spironolactone or mineralocorticoid receptor antagonist. And most recently, you always have heard of the medication called Entresto, which has one other substrate, which is a neprilysin inhibitor. What does the neprilysin do? Neprilysin is an endopeptidase and break down the ANP and the BNP. At the same time, it breaks down the angiotensin 2. Now, why ANP, what is ANP and BNP are doing? They're helping by removal fluid of our body. They're helping by dropping our blood pressure, and they're helping by reducing the proliferation of the cells. So if neprilysin breaks them, then you cannot have these favorable actions. So then we've discovered the neprilysin inhibitor that stops the neprilysin from breaking down those peptides. And as a result, we have an increased amount of those peptides leading to those favorable effects. Unfortunately, at the same time, we don't break down the angiotensin that we don't really need. And that's the reason that we combine the neprilysin inhibitors with angiotensin 2 inhibitors so that we get both of the effects. Now, moving to another path of the neurohormonal activation, we do have the catecholamines that they're rising when we do have the cardiac dysfunction and the initial myocardial insult, and we have to block them. Why? Because as the catecholamines rise and we have a sympathetic activation that leads to myocyte hypertrophy, leads to myocyte injury, and increased risk of arrhythmias, and down the road, progression of the disease. And what we have the beta blockers that you all know. Finally, we have the SGLT2 inhibitors. It's a little busy slide, but if you see here, the SGLT2 inhibitors block the channel that is a co-transporter for glucose and sodium. So what is happening is the glucose and sodium is secreted in our urine, and then it's reabsorbed in the blood. Now, by blocking the transporter, we lose glucose and sodium. As a result, in an osmotic manner, they also drag fluid with them, and that reduces the right atrial pressures and reduces the filling pressures of the heart. Of course, this is one of the effects that we know. There are many more effects that we don't know about the SGLT2s, and we're now discovering, going back to the basic research, and they can have favorable effects in the glomerular filtration. They can have favorable effects in the metabolism of the heart, favorable effects in the cardiovascular system in general, and more are going to come out about the SGLT2 inhibitors in the future. It's the latest addition in our heart failure management medication group. And now I'm going to pass the talk to Dr. Nair, who is going to talk to us about the heart failure with preserved ejection fraction and how this, what is the pathophysiology behind that.
Thank you, Dr. Diakos, Nikos, for a wonderful first segment. So if we look at heart failure with preserved ejection fraction, first of all, if you look at, if you go back to the initial slides and we go back to what Dr. Diakos is talking about, heart failure is quite ubiquitous and is a pandemic. And if you look at heart failure as far as this epidemiology, heart failure with preserved ejection fraction is actually growing in the United States. And so it represents about 50% of heart failure admissions in the United States. There are differences as far as clinical profiles between HFpEF, heart failure with preserved ejection fraction, and HFrEF, heart failure with reduced ejection fraction. Typically, those patients with HFpEF are older median age. They typically have a female predominance. They tend to have hypertension. And there's a high frequency of comorbid conditions, including coronary artery disease, obesity, metabolic syndrome, and renal dysfunction. And at the bottom there, you can look at sort of those same pressure volume loops that Dr. Diakos had presented several slides ago. And you can see there from the pressure volume loop standpoint, for a given volume, the pressures are higher, and this is as a result of decreased compliance. And whereas heart failure with a reduced ejection fraction has established guideline-directed medical therapy, there's limited guideline-directed medical therapy for heart failure with preserved ejection fraction. Next slide. If we look at morbidity and mortality rates with HFpEF versus HFrEF, of note, the morbidity and mortality are similar. This is a study that looked at, first of all, the population. Again, if we look at all heart failure in the United States, about 46% are HFrEF and HFpEF as well. And then about 8% represent this heart failure with mid-rate ejection fraction. However, on the right there, if we look at the 5-year mortality rates, you can see it's exactly the same. And if we look at the outcomes over 5 years with regards to mortality, readmission, cardiovascular readmission, as well as heart failure readmission, and finally mortality, they're roughly equivalent. So despite the differences in ejection fraction, the outcomes are the same. The difference here is that heart failure with reduced ejection fraction, by and far, the mortality is cardiovascular related and heart failure related, whereas in HFpEF, a lot of the mortality is related to the comorbid conditions that are associated with HFpEF. And that's why, sort of an emphasis on these comorbid conditions, as well as the different phenotypes of HFpEF is important. Next. So if we look at the pathophysiology of HFpEF, there are several different things that can contribute to this. This comes from a nice sort of ACC statement on HFpEF by Dr. Borlaug and colleagues from last year. So at its fundamentals, you have a cardiac pathophysiology that contributes to HFpEF. Then you have also an obesity cardiometabolic stress, hypertension and hypertensive ventricular stiffening that contributes to HFpEF, and microvascular inflammation. And if we start going through these things, you can click on these if you can go back. With hypertensive ventricular stiffening, there's increase in myocardial fibrosis, altered matrix structure, and altered protein expression phosphorylation. With obesity, there's decrease in myocardial efficiency, impaired RV contractility, greater senescent or myocardial stiffening, increased stress blood volume. With inflammation, you have increased oxidative stress, microvascular dysfunction, and vascular rarefaction, so you lose your vasculature. And then finally, with cardiac pathophysiology, you have structural abnormalities in all 4 chambers, and then you have associations with atrial fibrillation that leads to left atrial hypertension, as well as pulmonary hypertension that results from that. And then you have some non-cardiac mechanisms as well, including pulmonary renal dysfunction, skeletal muscle dysfunction, and deconditioning. So if we look at some altered signals in myocardial abnormal signaling, what you can see is there, going from left to right, you have comorbid conditions that, as well as renal dysfunction, that leads to systemic inflammation. All of that leads to multi-organ involvement. So cardiac impairments of muscle sort of VO2 extraction, sodium retention, as well as pulmonary hypertension. And then you've got endothelial cardiomyocyte signaling abnormalities that result from this. And all of this contribute to the pathophysiology of HFpEF. In addition to that, coronary artery disease is important to look for in these patients. There was a nice sort of study from the Mayo group that looked at the underdiagnosis of coronary artery disease in HFpEF patients. And here in this study, they looked at patients with HFpEF, and they found that obstructive disease was present in about 50% of patients, but you also had endothelial independent abnormalities and coronary microvascular dysfunction in about 66%, and endothelial dependent coronary microvascular dysfunction in about 25% of patients. So at its root there, you have inflammation contributing to both frank coronary disease as well as endothelial dysfunction in these patients. In addition to that, one of the key things here is that pulmonary hypertension can be seen in these patients as well. And this results from chronic left atrial hypertension. And this was another study that came from the Mayo as well. And they showed that in these patients who have HFpEF, they have a significant number of patients who have significant pulmonary hypertension. And when they look at it, they looked at these patients who had a rare form of pulmonary arterial hypertension called pulmonary veno-occlusive disease, where you have remodeling of your pulmonary venules that causes severe pulmonary hypertension. And when they looked at autopsy sort of specimens, they found that those patients who had HFpEF, who have significant elevations in their pulmonary vascular resistance, have similar remodeling. So you get pulmonary hypertension over time that remodels your vasculature and can cause some secondary pulmonary hypertension that behaves like group 1 pulmonary hypertension. So as the disease progresses, initially you get a loss in relaxation and decreased compliance, and decrease in longitudinal function. All of that leads to decreased left atrial compliance. You can have atrial-based mitral regurgitation, and then that leads to RV dysfunction, as well as remodeling and increased tricuspid regurgitation. And you can have these patients that present not only with left heart failure, but also with a right heart failure phenotype as well. So again, as Dr. Diakos said, later on in these grand rounds, in several weeks, we'll be discussing the treatment for HFpEF. But as I mentioned, the treatment is limited right now, but over the last 5 years or so, there's been an improvement in sort of guideline-based medical therapy for HFpEF. First of all, over the last 2 years, there have been seminal trials showing the application of SGLT2 inhibitors in HFpEF. And while there's not a strong sort of mortality reduction with the institution of SGLT2 inhibitors, there's significant reduction in heart failure events, including readmissions that occur for heart failure. And so SGLT2 inhibitors are now class 1 indications for the treatment of HFpEF. In addition to that, loop diuretic therapies remain as key sort of treatment modalities as a 1A recommendation for HFpEF as well. Without getting into too many details, other agents that you can use that target inflammation as well as neurohormonal activation that's also seen in HFpEF include a mineralocorticoid receptor antagonist. This was shown in the TopCat study to have a signal towards improvement. And then the same thing, these ARNIs, angiotensin receptor neprilysin inhibitors, specifically, the data was more significant for women with HFpEF, showed improvements in sort of primary outcomes of heart failure admissions and heart failure events with ARNIs. And then finally, in those who are ineligible, you can consider ARBs. So in summary, heart failure is a complex syndrome with symptoms and signs that result from any structural and functional impairment of ventricular filling or ejection of blood. Heart failure is a global pandemic with 64 million people affected worldwide. Heart failure can be classified into HFrEF, HF with mildly reduced ejection fraction, as well as HFpEF. The morbidity and mortality are similar between HFrEF and HFpEF. And then heart failure, reduced ejection fraction, cardiac dysfunction leads to neurohormonal activation and subsequent hemodynamic decompensation. There are 4 core groups or pillars of medications for HFrEF. And HFpEF is multifactorial underlying pathophysiologic mechanisms that produces different phenotypes. And currently, the treatments include spironolactone, SGLT2 inhibitors, ARNIs, diuretics for HFpEF. And then the last slide that we'll have today is sort of a simplified sort of approach to referrals for advanced heart failure centers. And this is important. We were having discussion yesterday with Dr. Brown's group, and I think we had talked about sort of early referrals necessary to improve outcomes when we talk about these patients who proceed into stage D heart failure. And the symptoms and signs to look for: a need for inotropes, high natriuretic peptides, end organ dysfunction, low ejection fraction, defibrillator shock. Hospitalizations is key. So if patients are coming back in, you may want to think about a referral for advanced heart failure care, edema, escalating diuretics, low blood pressures, and then prognostic medications, meaning that you can up-titrate, or maybe you have to cease guideline-directed medical therapy. So we want to thank you, and I think we'll open it up now for our discussion with Dr. Brown.
Great. No, thank you, the presenters. Amazing the clinical advances in clinical understanding and intervention. As a medical student, I was taught that the definition of heart failure was the lack of heart success. So we've come a far way from that point. We have the question and answer posting available. One question that came to me that I'll ask Dr. Brown and others to comment on. Certainly there's been a lot in the press about cardiac disease in athletes, especially elite athletes, and this condition sometimes dubbed as athlete's heart. And is that a cardiomyopathy or not? And is there any special attention that needs to be paid to elite athletes that are referred, especially if they have, echo evidence of ventricular hypertrophy? Dr. Brown?
So that's a little bit of a different topic than our presentation, but I will say that the current knowledge is that an athletic conditioning, a true athletic heart, is a reversible condition. And so when you look at their heart on echo, their diastology is normal. They may have some thickening of their ventricle and a little bit of dilation of their left atrium specifically, but with decrease in training, all of that remodeling goes back to normal. But if you have an athlete who has significant changes in their size of their left ventricular thickness or their left atrium and abnormal diastology, then that is not athletic remodeling.
Right, thank you. Another question, are there any predictive models that exist that can help our primary care providers calculate the patient's risk for developing heart failure in the at-risk category, similar to the CV risk prediction used for hyperlipidemia therapy decision-making?
So Nikos can chime in. Right now, as far as the development of heart failure, I think we only have sort of those patients who we have with stage A heart failure, that we have comorbid conditions that contribute to the heart failure. As far as the risk of developing that, it's a little bit more of a nuanced sort of approach, I think. We certainly have risk calculators as far as mortality is concerned with HFrEF and HFpEF. We commonly use the Seattle Heart Failure Score. There's a MAGIC score. So there are several scores there that can be utilized for prediction of morbidity to mortality with heart failure. As far as overall risk, I think, outside of genetics, some of these are a little bit more difficult to predict. But if you look at sort of the trials over the last several years, especially the hypertension trials, SPRINT, et cetera, the number one reduction in sort of events with blood pressure control was heart failure events later down the line. So I think this is something that we'll have to obviously refine, and then it becomes a little bit more complicated when you look at kind of current sort of societal projections as far as comorbid conditions, and a lot of that's going to lead to HFpEF, and I think there's a lot of phenotypic divergence with HFpEF, so I think more to come on that. Nikos, do you have anything to add?
Yeah, I agree that, the stage A is really meant, the stage A of ACC-HA is really meant to keep those people on the close look. And what I like to educate my patients, like it's kind of, if you talk to patients, they say, oh, I have to take control of my high blood pressure because I'm going to get a heart attack. I'm going to get a stroke down the road. Well, in reality, yeah, that is true, but it's also equally important to control the blood pressure because they may develop HFpEF down the road, and that's what many people don't know. And then you may see in your initial screening some diastolic dysfunction in your echoes, and that I use it. Patients that are asymptomatic, I don't usually call them HFpEF if they just have some echo findings, but I use it in my benefit to educate the patient. Like, listen, you have hypertension for like 15 years right now. You are at risk of developing heart failure, and I can see that you have started developing diastolic dysfunction in your echo. You don't have the syndrome yet, but you may develop down the road. So yes, this population that has the risk factor is at higher risk, and they need to be educated.
Thank you. Another question on diagnosis. So if you're obviously not using EF as a diagnosis criteria for HFpEF, then what exactly are the diagnostic criteria? Is it the signs and symptoms themselves?
Yeah, it's a combination. So we have diastolic dysfunction of the heart. That there are several markers in the echocardiogram, and we have the symptoms. So when you marry the symptoms with the echo findings, then you can call it HFpEF. It's not necessarily someone that have some diastolic dysfunction markers on the echocardiogram that are getting into this box of HFpEF. They are at risk of further developing symptoms when you see these markers on the echocardiogram. So it's the same as HFrEF. It's a syndrome, and it has findings in the echocardiogram and symptoms. Of course, as Dr. Nair is going to tell you, and Dr. Brown, the gold standard, is doing this exercise, right heart catheterizations to kind of see the increase in the filling pressures in a patient with normal ejection fraction when they exercise. But that's not all the time that we're doing. Is that correct, Dr. Nair?
Yeah, so if you look at no, thanks, Nikos. Yeah, so the it's a clinical syndrome, so you have to marry sort of the clinical picture of a shortness of breath, fatigue, etc., with the fact that the cardiac output is compromised, or it's only sort of functioning with higher filling pressures. But ultimately, if you want a gold standard, especially one that we use for trial inclusion for many of our different HFpEF trials, what you want to see is a elevation in your wedge pressure. So strictly speaking, many trials have shown that or many trials require that the wedge pressure go above 25 with exercise. And we see this quite a bit where patients, I mean, this is really HFpEF is not so much of a sort of impairment at rest, but it's really causing a functional impairment. And so we see this quite a bit in the cath lab if you exercise patients. And we have, for example, we have an intra-atrial shunt trial right now that's ongoing, that's trying to offload the left atrium and offload it in the right atrium. It's sort of a proof of concept as far as I'm concerned, but it's interesting. And part of the criteria is that you exercise patients, and we have a supine bike that we use in the cath lab that you can adjust a workload, and we do exercise-based SWAN measurements, and if the wedge pressure goes above 25, then we've diagnosed that patient with HFpEF. The other thing that you can do is, if you want to stay away from invasive studies, is diastolic, stress echoes. And I'll defer to Dr. Brown because she does a lot of imaging. So, Jessica, do you have that's sort of what your viewpoint is from, sort of an imaging slash right heart standpoint?
I think with the right heart catheterizations, obviously we see elevated filling pressures. Oftentimes their cardiac output is normal, but sometimes it can be a little impaired, and you'll see when you exercise that their filling pressures increase. For stress echoes, we'll see without an invasive study, you can mimic that and see the diastology change as they exercise. So those can be helpful, but they are pretty specialized studies, and not your usual echo lab may not be able to do them.
Yeah, the only other thing I would add is that we use also biomarkers, and so the BNP or NT-proBNP become, sort of central to that diagnosis as well. As you know that, HFpEF typically carries, sort of lower BNP values than HFrEF, but, still can, be confirmatory of that diagnosis.
So because
Thank
I see
you.
also in the audience saying when do we start SGLT2s, along what Dr. Brown and Dr. Nair said, what do you guys like? Do you wait? Like, do you need a right heart cath to start it, or if you see someone that has diastolic dysfunction on echocardiogram, he has a BNP elevated at the 300s and is short of breath and gives you a story on exercise. Do we need a right heart cath before we start SGLT2, or we just start SGLT2?
I would say in that clinical situation you've described a HFpEF patient, you would treat them accordingly.
Yep.
Yeah, and then there was a question there that this is a little off track, but regarding resource limited areas, and that's something else that we take into account when treating these patients. I don't think we can, at least in 2024, get around the cost of some of these medications, specifically SGLT2s. And in addition to that, ARNIs as well. So while SGLT2s have been a remarkable success story, they at times can be cost prohibitive. So I think that's why it's sort of important to take a deep dive into the data, and know sort of what you're sort of reducing as far as the SGLT2s. And with HFrEF and it's a mortality reduction. With HFpEF, it's a reduction in heart failure admissions that you're getting. So, if you've got someone that may have limited resources that hasn't been admitted, I tend to take sort of the cost of these medications along with the, socioeconomic background, into consideration, and know, that these medications are probably reducing wedge pressures. They're reducing, hospital admissions specifically for heart failure, not overall hospitalizations, but, for heart failure specifically. And we know that HFpEF patients get admitted for all sorts of other reasons, COPD, whatever. And so we have to take that into account as well. I think in the community-based centers, especially low-income, sort of areas, we have to look at those stage A and B patients and try to prevent the progression there. And then we see a lot of this where I think it's important in our community centers as well as in our county hospitals to not only, sort of triage these patients that may have advanced heart failure early, but also implement guideline-directed medical therapy. And then again, do what's reasonable. I mean, we still go back to using ACE inhibitors and, bisoprolol and maybe spironolactone in patients, and these have significant mortality benefits on their own. So, you have to be sort of cognizant of these, social determinants of health as well when approaching heart failure patients.
No, thank you. We have a question regarding exercise advice. And the scenario provided is a patient with an EF as low as 35% who has relatively few symptoms. What do you advise for their exercise, and will exercise lower their future risk of problems?
Yeah, I mean, I recommend exercise. I mean, I do tell them that this is not going to improve your ejection fraction, number one. Number two, as far as mortality is concerned, I think if you look overall that, it will have some degree of mortality reduction from a cardiovascular standpoint overall. From a, heart failure perspective, the data is a little bit more equivocal when it was studied in the heart failure action trial. But nonetheless, I think if they do exercise, have improvements in functional capacity, it will typically result in lower sort of event rates. And then finally, I think the thing to, keep in mind too, that I stress to patients is that, the heart is serving a job as far as delivering, blood, and, with that delivery of blood, the whole purpose is oxygen uptake. And so it's important to maintain sort of end organ health, specifically muscles as well. And so exercise will allow for improvement, more efficient muscle sort of uptake of oxygen. And that's ultimately what we're trying to achieve from a metabolic standpoint. Exercise, I mean, about 140 minutes a week, 30 minutes or so of walking is sort of what we start off with. But then, as it goes forward, you can have, there's a nice Jack statement from a few years ago from Dr. Boskurt, who's at the VA here in Houston. And, they recommend about 60-40 with cardiovascular sort of based exercise and about 40% with resistance-based exercises.
John, I think we've got time for those last two questions there.
Yeah, thank you, Gary. So one has to deal with further evaluation, considering 50% of the patients with HFpEF have obstructive diseases. What testing would you recommend to further evaluate for this?
So for these patients, as we discussed, they have a lot of comorbid conditions. Many of them are hypertensive, diabetics, also have hyperlipidemia, are older. So they have risk factors for traditional coronary disease. So I think that you would go down the pathway of evaluating them for obstructive disease. If they're a very high risk patient and they have typical anginal symptoms, there may be a role for going to direct angiogram. Otherwise, if they have risk factors, you can always use a functional study, a stress perfusion study, a stress echo to evaluate them for inducible ischemia.
Great. And actually, the remaining questions, nearly a half a dozen, have to do with therapy. So I think it's best to postpone those for the next session that will be dealing with therapy. I want to thank our panelists for erudite discussion. Also offer their services to any attendees for future questions and advice dealing with their patients with any form of cardiomyopathy. So thank you all. Gary, concluding remarks?
Just saying thank you so much. It's eye-opening, enlightening, and every time I hear these kinds of talks, as someone who's been doing this for a while in primary care, what a different world it is, and what a better world it is with the work that you're doing. So thank you extremely very much, and we look forward to the next couple of sessions. And I just want to thank Dr. Flynn and team. Dr. Flynn called us some months ago and said, is there an area that you'd like to have Baylor College of Medicine collaborate in a series of grand rounds, and this is what came from it, and we're very appreciative, and I think it's just absolutely great that we can share this with the community across the country. So thank you all who joined us as well. Everyone has seemed to stay with us, which is always a good sign, and we hope people have a restful and safe weekend. So thank you very much.